Okay, so our next theme is how superintelligence will eradicate the world disease and suffering. Our speaker is Dr. Hector Zenil, the founder of Oxford Immune Algorithmics and an associate professor at King's College London. And Dr. Zenil holds dual PhDs in computer science and philosophy, and his career has spanned from the Karolinska Institute of the University of Sheffield. He is at the forefront of applying algorithmic dynamics to some of humanity's most complex challenges. Thank you for waiting, and thank you for coming. So please take it away.
Hello. Is it working? Yes. Perfect. Thank you very much for the invitation, and thank you for coming. How do you change the... Is it with this one? Okay, perfect. So one of the motivations that I have both in my academic career and industry is what I call the human condition, which is a lot of people suffering for different reasons. And I don't know if you are surprised by these numbers, but I was when I learned this a few years ago. Actually, it is not wars or accidents that cause the greatest suffering in the world. The greatest suffering in the world is caused by what is called the silent killers. And in particular, two main diseases. One is cancer, and the other one is cardiovascular diseases. These two things are basically responsible for about 70% of the suffering around the world. And people can lose up to 15 to 20% of their life having bad or poor health, and actually die many years before they should have. So around 25 years are spent either dying too soon or in poor health. And this is the human condition, and many or most of us basically go through all of this because this is a global average. So what is preventing us to actually try to do something about this? And in my opinion, it is three main things. One is we have overburdened clinicians and a huge staff shortage of clinicians. We are not training enough doctors and nurses. And the national health systems are realizing the only way forward is automation and machine intelligence. The other thing is that we live in a very unethical health system. Basically, you only get medical attention when you are ill. And hospitals and doctors are paid only by how many ill people they treat, instead of how many people they keep away from labs and clinics. We call this sick care because this is really a reactive system in which, as I said, only when you are ill you get medical attention. And the whole system is built around this idea. Even drugs, when you go to a pharmacy, most of them are really to deal with symptoms or with people that are already ill and not really to keep them healthy in the first place. And that's because we really don't understand the transition between health and disease. We understand better disease than health. So something we have to do is to change this reactive sick care to actual proactive health care. And the other third point is there's a huge unequal access to healthcare. Not only in developing countries, but even in developed countries, it is not the same to live in the countryside than in a large city with a lot of hospitals. And you may be lucky enough that you have a very good GP or medical doctor, but maybe you are not, and you were unlucky, and basically you get misdiagnosed. And that is, I feel that very something very unfair. So this is the situation today. Even in the UK, where it is supposed to be a developed country, you have to wait on average 21 weeks to get a phlebotomist appointment. That is to do a blood testing, a regular one, if you are not in an emergency. It's huge. Even myself, I've tried to get a B12 shot because I require it, and sometimes it takes me like 2 to 3 months. So national health systems are under a lot of pressure. And during the pandemic, we learned that actually we could do things differently. So for example, virtual care now, it is something currently happening all the time, but it is still quite small. And to be honest, it is quite shallow and superficial, because we are trying to replicate what happens already with a GP, which is to have just some sort of discussion or a chat with a patient. It is not really data-driven, and we have taken that to the virtual space, that personal experience, not doing much more. But we believe that in the future, this is going to be enabled and improved by AI, and is going to be increased in the future. We already have some examples. So for example, in China, there was a very interesting example, an experiment with what they call the hospital of the future, where they had some sort of agents interacting with each other, trying to replicate what happens in a hospital and see what happens. That was just a toy example, because it was not really doing any real diagnostic on real patients. But we think that the world is moving to that direction, especially because we know our limitations and constraints. As I said, we are not really training enough doctors and nurses, and this is only becoming worse and worse. Even the NHS in the UK now has a mandate to keep people at home. So they don't really care how much they spend, because they cannot treat them in the hospital, and you can see the waiting times that they have. This is only for blood testing, but pretty much for everything else, including emergency care. There's some places in the UK, including the north of England, where for emergency care you have to wait like 20 or 25 hours. That is not sustainable, and that is actually not any standard of care. So this is how we think the transition is going to start to happen. And this has already happened with things like the thermometer, for example. So things like the blood pressure device that allows you to monitor yourself at home. It is the future of healthcare. And now we have more and more kind of these point-of-care devices, including, for example, the glucose meter that basically changed the game dramatically, multiplying the number of sugar tests by 10x by moving basically this lab testing, measuring sugar, to people's homes, creating a new market. And my company and the research that we are doing is basically to try to perform blood testing at people's homes, and you are seeing some of the device on the screen, and actually I was able to bring one of them, and you can see it looks like a point of care, but actually you can perform the most popular blood test with this device. It is called complete blood count. It is related to the immune system, and I'm happy that Anna was able to cover a little bit about the immune system, because together with the human mind, I think it is one of the most impressive systems in the universe, potentially, I mean, that we know of. Because of the way it interacts with each other, it recognizes cells that are our cells or are not. Sometimes it goes wrong, and all these, for example, neurodegenerative diseases and inflammatory diseases are most of the cases immune cells going wrong, attacking the body. But we have created these small devices, and we have a few patents in the US to keep making this lab testing equipment smaller and smaller. Because basically there has been, in the history of humanity, a technological convergence towards doing more with less, and with devices that technology pushes to people's homes. You name it. Think of the car, the fridge, the microwave oven, the phone, the personal computer. All this transition of technology has been about making something that was originally large into making it smaller, cheaper, and easier to use. And even services, in the 90s, you may remember we used to go to the cinema theater, and today basically we can watch any movie, anytime, any date from home. And we think that this is going to happen also with healthcare and medicine, and it is happening as we speak. And we are contributing with our own devices. And why this is going to transform many things, because currently the system treats everybody as if they were the same. It is population healthcare. Right? For example, when you do some blood testing and you get the results, they always tell you whether either you are within normal reference values or not. And those reference values you are measured against are huge, because they are basically population averages. And there's a beautiful paper published at the beginning of this year on Nature from a Harvard group, here is a reference, showing that basically every one of us has a different set point, meaning that our immune system is completely different, and we are basically measuring in the wrong way. It is too trivial. They show that not only every one of us has a different set point or health baseline, but when you move within these normal reference values, we are basically missing a lot of key biological and clinical information, because you can be up to 3 to 5 times more likely to die by moving from one side to the other, all within the normal reference values. So if you go to the GP, they will tell you always you are perfectly normal, no follow-ups, and still you are showing some stress, health stress within your blood system and the immune system. So we are missing all this information, and we think that it is underused, the potential of blood testing, because 70% of diagnosis goes through blood testing or involves some blood testing. So it is huge. The other 30% is about imaging, so MRI and those kind of things. But basically, these are the two main tools that humanity has to basically make a diagnosis. Blood testing and imaging, pretty much, together with symptoms and other things that are not necessarily very objective. So this is how personalized healthcare may look like. This is how the World Health Organization and most national health systems tried to push during the COVID pandemic, because the idea was to vaccinate the whole population at the same time, as fast as we could. Obviously, it took several months, but the mandate was actually to vaccinate everybody at the same time. And sometime later, it would come a boost, because the idea would be to push most of the population above the threshold of herd immunity, which is basically the point where everybody is kind of protected, because the virus finds someone that has been already vaccinated and is immune to that virus. But that was completely inefficient, and you can see what happens actually in reality. On your right, we have a study with 4 patients. So instead of putting everybody like in a population plot, we have 4 patients on your right that have completely different reactions to the same vaccination scheme. So when they provided the second dose, the blue patient, for example, had the expected reaction and got some sort of protection from immunity. But the other ones actually had a much weaker reaction, especially the purple one had almost no reaction whatsoever. So it was not really protected with this scheme that is looking at population. For those ones, they should have got more shots. And actually, it is completely inefficient to try to vaccinate everybody at the same time. Inefficient and expensive. We should have been tracking the antibodies of every people and actually be smart, because we could have saved lives. People that may have died are actually those in the purple line, for example. And this is what we can change. And this is all blood testing, by the way. So antibody detection is through blood testing. So the immune system basically mediates between what we know about health and our actual current health, because it is the system that is policing the body. And we wanted to do is basically to come up with some technology that would be monitoring the monitors, the immune system. And we have here the first device that we pushed to England hospitals. So we have 2 of these devices already with hospitals at Cambridge and King's College. And then what we do is to collect all the data with a platform. And on the data side, this is basically just using and putting together the 10 or 15 years of research in applying AI to cell molecular biology to understand the immune system, to try to derive the set point of every person, and then flag for small changes even within the normal reference values. So what we do is to actually start narrowing down those reference values to each person's own personal values instead of taking population values. So this is very powerful because basically we have AI that has learned from yourself and only yourself, and then flags for very small changes. And then the platform also collects all sorts of symptoms and also allows clinicians to get access and support for differential diagnosis. Differential diagnosis is basically a way to try to discard things that are not really related to your health issues. So the system basically creates hypotheses behind blood testing and the symptoms that it collects, and builds these questionnaires on the fly, and basically pushes us to the patient. The patient answers those questions, and behind the scenes we can either confirm or reject the diagnosis hypothesis that the system has. So eventually this is going to get so powerful that we can replace primary healthcare. And we have tested this against 10,000 patient cases, and we got 100% right, because actually the most difficult thing is how not to give the medical doctor more information that they require. So the difficult part of this project was actually to find the right threshold, not to provide too much information that the doctor would actually spend more time on using this system than doing it everything by themselves. But there are also some limitations from medical doctors and human doctors. When you go to them and basically you do your blood testing, in the best case scenario, they only compare your last blood test result with the last one. Best case scenario, perhaps the last 2. But it is impossible for a human doctor to basically try to understand your whole history in the time span that they have to treat you, which is about 20 minutes. So there's no other option but actually to have AI to understand people's health and people's history and all the information that a medical doctor should actually take into consideration to make the right decision. So this is how the device looks like, and it also uses AI, because the idea is to push this device to people's homes eventually. There's nothing like this on the market that it is portable. And what we do is to make up for the expensive optics and electronics with advanced AI. So with the electronics that we use, we take low resolution images, and basically we have to use AI to improve those images to perform as good as a large and more expensive medical device that sits at the hospital. And the idea is to basically take people through a system where we can flag for small changes by monitoring people, by having one of these devices at home so that they can regularly monitor themselves over time. Because it requires time to learn from the user, and actually we want to start doing this as soon as possible, especially when they are healthy, because that's the transition that we want to understand, when they transition from being healthy to becoming ill. And this is what we are also doing on the research side. So this is what we call disease signatures. And we have a signature for every disease, and so far we have collected 200 of these diseases. And each of these lines is a time series of an analyte. An analyte is just a biomarker in your blood test. So, for example, if you look at bacterial versus viral infection, you can see that the analytes, for example, the neutrophils, which is a type of white blood cells, has a very different behavior than in the other case. So by looking at this signature or patterns, we can basically tell apart one disease from another by blood testing a person. And then what we build is what we call disease networks. And first we build a correlation network. So when one biomarker has a similar behavior to another one, we make a connection. But this is only correlation. We then go to the medical literature to try to actually make sure that that connection is causal. So there's a mechanistic explanation between those biomarkers. And if there's no causal explanation, basically we break the edge between those two biomarkers. And then those causal networks are used to make predictions and actually simulations. So you can simulate intervening in the lifestyle of a person to see how their blood test results are going to look like in the future. And then you start doing all sorts of interesting analysis and simulations towards building a digital twin. We call it a digital blood twin, because over time we are going to have so much information from the patient and also symptoms, lifestyle, clinical history, that we start building some sort of twin of that person with which we can do simulations and even interventions to see what is going to happen. So this is the future of healthcare and medicine. And we have built some very powerful algorithms that we have tested against the best predictors of time series. These are specialized LLMs. For example, there's one called TimeGPT. And we have tested how good we are with our own AI to predict time series, especially related to medical records. We outperform the best LLM predictors. So we think we have a very powerful technology that we are already placing at medical hospitals in the UK, and hopefully in the next year or two, we are going to be able to start launching in other regions. So we used also our own test to test other regular LLMs and their claims about AGI and superintelligence. And we found that actually they don't do very well. And actually new versions of LLMs sometimes show regression. So they don't progress over time, but they are not reaching like an ultimate goal. Sometimes they go back. So that was a very interesting case. So I'm going to stop there without first recommending you, if you are interested in these topics, I have published a few books. These are the two last ones published by Springer and Cambridge University Press on algorithmic information dynamics and methods and applications of algorithmic complexity. So thank you very much.
Dr. Zenil, thank you very, very much.